Hi, and a very good evening to one and all watching us on Facebook and to our friends who've joined us on Zoom. It's indeed a great pleasure to be here as a community once again. And this is indeed a very, very special session. I think it is special because we have three very, very special people with us. We are discussing a topic so special to us, and probably the topic that is most spoken about within the CKD community and fraternity. And to set a stage to what this particular discussion is going to be about is, in this discussion, we aim to bring out the best of information that will help our CKD patients who are transplanted, give them a sense of clarity, give them the confidence to know where they stand in terms of the vaccination and how we are moving forward. And without further delay, we have, like I said, three amazing, excellent professional doctors. To begin with, we have Dr. Sanjeev Gulati. All the three doctors need no much introduction to the community. I think they've known so well. We all love them so much, but it's still a pleasure to share a line or two about each one of them. Dr. and Professor Sanjeev Gulati, the Chairman, Nephrology and the Kidney Transplant Fortis, GP of Hospitals NCR. Wherever you are this evening, I'm going to request you to please give a warm hand of applause. We will receive your love wherever you give us a hand of applause. Thank you, Dr. Sanjeev, for joining us this evening. We also have with us Dr. Narayan Prasad, the Professor and Head of Department Nephrology of Sanjeev Gandhi Postgraduate Institute of Medical Science, Lucknow. He's also the Honorary Secretary of the Indian Society of Nephrology. Thank you very much, Dr. Prasad, for joining us this evening. And a big hand of applause for Dr. Prasad.
Thank you. Thank you.
And of course, we move on to our very loving and well-known doctor who's been a part of our day-to-day discussions in the community, Dr. Sundar.
Okay.
Can we request everyone to be muted, please? Dr. Sundar, they head International Transplant Services of Manipal Hospitals and is the ex-chairman of the Indian Society of Nephrology. And with that, these are our three doctors that we have with us this evening. And like I mentioned, it's time we directly dive on to the topic. But before we actually get in the topic that we all want to talk about, that is the vaccination in transplanted patients, let's first set a tone to what this period of the last 2 years or 1.5 years has been like. Life has been very different for us, whether you're in the journey of CKD or a caregiver or a donor, or if you've just been a normal human being that's surviving any part of this world. So let's start with some love and empathy of knowing how we all dealt with this period. And then let's move on to our discussions and the Q&A the community had through their questions. So the one thing that I definitely do not know is what is life been for doctors. You know, I'm sure everybody has just been calling but there's so much of change that happened to doctors in terms of the way they consult. There's so much of adaptation they went through. There's so much of emotional and mental struggles they probably faced in their own practices, I'm assuming, because it's been very different for everybody. So let's hear that side of the story. And to begin with, Dr. Sundar, I'm going to start off with you, Doctor, because I remember having a sneak peek conversation. How different has your practice been in this last 1.5 year?
I think starting from last March, April, it has been quite a scary thing. In February, I went to UK to see my grandson, and then came back and the pandemic started. At that point of time, I think in our whole career, I mean, I'm in the field of medicine. I passed my MBBS in 1976, so it's nearly 5 decades. We have never seen this sort of, I mean, we have seen deaths. I mean, not as doctors, we don't see deaths, but we have not seen this scale of devastation in our day-to-day life, no? And actually, the first wave was not so bad, to be honest, because we had beds and somehow I was not so scared. But this time, the second wave has been quite scary. In fact, I have lost more patients this time, and we have lost quite a few colleagues of ours. And more importantly, we are sort of, we felt helpless because we couldn't arrange beds. My close colleague of mine, her own father, a transplant recipient, and I could not get a bed for him, a friend's colleague's father. I couldn't get medicine and we lost the patient. And that still haunts me. The guilt still haunts me. I feel my own colleague's father, I'm not able to help. But this is the case every other day. Whenever I get a call from somebody, say, Sanjeev calls me from Delhi, I'm worried. I'm hoping that he is not asking for a bed for his friend or relative in Bangalore. So that is the fear I had. And that fear continued. Thankfully now, thanks to lockdown and other measures, things have changed. We have got back to work and more or less near normal work is going on. But it has been a very eventful year. And even our own practice, what we are doing day-to-day practice has changed. We are doing more of video consults. We are doing more online things. But still, I am a people's person. I would still like to talk to my patients in person, see them, touch them. That I believe in that. I hope someday we'll come back to that. Let's see how it goes on. But it has been a troublesome year because of the deaths we have had in our own community of doctors. We have been from Bangalore itself. We have lost 3 nephrologists who died due to COVID. So it's quite a frightful situation. I hope God gives us the courage to go on well and help our patients. I think that is the most important thing. And I think in one of the things that is important is definitely vaccination. There's no two things about it. We'll discuss this further. Thank you.
Thank you, Dr. Sundar, for being so honest, so vulnerable, so open about how life has been on the other side. And now let's hear it from Dr. Sanjeev.
Yeah, thank you, Maryann. So I think Sundar has very aptly summed it up. It's been, I think, one of the most difficult years for all of us, be it our professional front, be it on the social front, or be it on the family front. And never have we felt so helpless or so frustrated, as has been, and then particularly in the second wave. And I think we are lucky that we have survived this. I hope the worst is behind us. This virus is mutating, and this is not the end. So if we have to stay a step ahead of the virus, we have to, vaccination, I think, is the cheapest, the time-tested, and the most important preventive measure. We have learned from previous infections. In fact, 2 notable infections, smallpox and polio, could only be controlled because of vaccination. And the funniest part is, despite all this, never has there been so much of confusion about vaccination as this time. There were times that I was getting about 50 to 70 calls a day where people just wanted to find out should they get vaccinated or not. So I think that way, I think this forum, I think we should try and set this at rest. And I'll end on this note from Gulzar, saying that, which aptly sums up how this pandemic has affected each one of us. एक वायरस मेरा कीमती खजाना ले गया, एक वायरस मेरा कीमती खजाना ले गया, दोस्तों के साथ बैठे जमाना हो गया. So if you want to get back to life, normal life again, there is no better thing than a vaccination. Thank you.
Thank you very much, Dr. Sanjeev and Dr. Narayan Prasad. How has practice been for you in the last one and a half year?
Yeah, thank you. Thank you for, first of all, for this opportunity to be part of this meeting, or this so-called CME on post-transplant vaccination. And actually, I'm just working out of 3. I am the one who is working in a government institution, that is public sector institution. So that was totally different ball game. When we have seen this much of the coming, there were a lot of government pressures to start on the COVID, convert this hospital into the COVID hospitals. So there was one area which has been chosen of the 200 beds of for the COVID hospital. But within a short span of the time, within the 2 weeks, the whole hospital was full. So that was very scary. And then at that time, government was not allowing us to dialyze the patient on the OPD basis. They want those who are getting infected should be admitted. So there was a lot of scarcity of the beds. Then we are very much confused how to deal with this. So we have created 12 extra beds of the hemodialysis in our RCH COVID hospitals. There the patient has been dialyzed round the clock. At the top, at the same time, many of the renal transplant recipients were coming to us. And in the first wave only, we have admitted 122 renal transplant recipients in our RCH hospitals. And I am very much pleased to announce today that only 10% of that serious patients have died out of this. We have been able to save most of the patients. So that was the one things which was giving us the satisfaction. And that death rate in mortality in a renal transplant recipient was the least across the world when you look at this. And these are the data with all of us. So I think that would gives us the satisfaction. What are the positive points? Also, you can think of always not of the negative things of this. You have learned many things new, and you are living in the new normal life. Like they were talking all together. It is not looking like meeting to Dr. Sundar was very difficult to travel to Bangalore. So we are so this new normal kind of the conversation between the each others came into the existence. New normal, you can think of the teaching and other things went there. And it was very challenging for all of us to give the training. Our students in the second year had 2 years was not that much exposure as used to happen the 3 years before. So that was another burden on our head, how to get them trained for the transplantation. Transplantation was off for some time, but purposely we have started renal transplantation. In the first wave duration, we have done 50 renal transplantation. Now again, we have resumed renal transplantation. Looking at them, there are news that many of the patients awaiting transplantation are dying. These deaths are more than those who are acquiring COVID-19 infections. So COVID-19 disease. So there are so many things to balance out of this. And so this COVID-19 has given you a lot of educational things also, so that you should learn how to adapt to the adverse of the situation. So on that note, I will end here, and definitely I will take up a lot of questions about this, what Dr. Gulati has pointed out or Dr. Sundar has pointed out, the renal transplantation and vaccination. That is the one of the hot topics of this day. We'll take up some of the questions from the audience and we'll discuss later on.
Thank you very much, doctors. Ideally, I would have loved to take up a case study from each doctor at what happened in one of the case studies, but I think I'm going to keep it for the end if we still have time, because we'll get into questions and we'll see if we have time to do the case studies. So let's start off with Dr. Sundar. I'm going to start off with you, doctor. And like I said, the whole intention of this particular session is to kind of give clarity of what is exactly happening with the vaccinations and why is there so much of confusion within the CKD fraternity. Obviously, there is a lack of information or knowledge, and patients are confused of what is happening. And I hope this session can give them that clarity and they would be more confident and take ownership of their actions, okay? So before I start off with the vaccination, Dr. Sundar, could you tell us exactly what happens when the virus attacks the human body and how exactly does the body defend itself from the virus? So then we move on to say how the vaccine plays its role over here. So can you give me that answer in as soon as possible?
I think, Maryann, you put it in simple terms, how the virus, if you read Robin Cook's novel, he says, God has created mankind for viruses to live. We must understand that now first. I think virus is such a small thing. It has brought the whole world to its knees. And once, the virus is like, it's a foreign thing which comes into our body, and your immune mechanisms identifies the virus, which tries to attack. And that is the thing which is something in COVID, which we have not seen in other viruses. And we have seen lots of viruses. And virus has been there for a long time, whether it's influenza, you talk of Spanish flu, it's been more than 100 years. More than that, we have been seeing that. But the most important thing we must know is, in COVID, in my own feeling, you rightly said there is so much confusion. Even as doctors, we still don't know. A man like Anthony Fauci, who's supposed to be the guru of infectious disease, he himself has kept changing his stance on various things, starting from masks, starting from vaccination. So we are still learning. Every day we are learning and new things come in. That's why it looks different. What advice we give last year may be different what we give now. But definitely one thing is certain, that only way where we can face this onslaught is by vaccination. And that vaccination works on the immune system. Your virus, when it attacks you, your immune system acts. And one of the problems with COVID is if the immune system overreacts, then we have got something called cytokine storm. So more than the virus, the immunity itself kills you. That's where we are trying to learn and work on that. I'm sure my brilliant colleagues Sanjeev and Narayan will be able to give you more insight onto this.
Thank you, Doc. I think now that we understand how the virus works and what exactly happens in the human body, Dr. Prasad, your question is, how may COVID-19 infection differ in transplant patients when compared to other normal people?
Yeah, we all understand, or most of our audiences might be understanding that he is getting this immunosuppression. Most of them are on prednisolone, steroid plus mycophenolate mofetil, calcineurin inhibitors. So these drugs are immunosuppressive medicines. So their immune system is already suppressed. So they are very prone for developing infection. First of all, once they develop infection, then whether this clearance of the virus would not be that great as it will happen in the patient with the good immunity level. So the clearance of the virus becomes problematic in renal transplant recipients. That is again, this very bad for the renal transplant recipients getting this COVID-19. Other important things are only then these patients on immunosuppression have relatively less symptomatic. What happens, the patient might have, because the steroid and calcineurin inhibitors do not allow them to have this early symptoms like this fever, and that remains relatively suppressed, but might be having the ongoing infection inside the body. So recognition also might be delayed. So this is the reason how these renal transplant recipients might differ in their presentation. They are at high risk of infection. Once acquired infection, very difficult to clear the virus. Clearance is more difficult than. Only advantage is that the patient who acquired infection, cytokine storm kind of things can be relatively less because these patients are on steroids. So that might be relatively better, but definitely the clearance of the virus becomes so difficult that ultimately these patients have the worst outcome as compared to your normal patients developing COVID-19 infection. So we all must understand the renal transplant recipients are very much vulnerable for the infection. Once they acquire infection, difficult to get rid of the infection, and then the chances of going into flare of the disease. Viral clearance is very late in renal transplant recipient as compared to your normal population. We have seen in our own study, case study, clearance in the normal population is average of the 2 weeks, but in renal transplant recipient, it is taking up to the 6 weeks, sometimes even to 8 weeks. So that is some differences you can notice in renal transplant recipient than the general population.
Thank you, Doctor. Dr. Sanjeev Gulati, the question that I'm going to ask you is a question that maximum number of patients has asked, and I think this answer is going to create such a difference to a lot of patients out there. Patients who have not taken the vaccination and patients who've taken the vaccination but are not convinced of why they've taken the vaccination. The general understanding and the advice given to transplant patients is do not take a vaccine. And now suddenly we have been asked to take a vaccine. And what we understand, the reason that we're asked not to take a vaccine is because the science and logic works right against the immunosuppressant patient, right? So how safe is it for us to take the vaccine?
Okay, so first of all, I'd like to correct you that among in the nephrology sciences, we have always been vaccine advocates. If you look at two specialties who have been most active at advocating vaccines, it's the pediatricians, because children are more exposed, and second is the kidney patients. Yes, there are some vaccines which have to be given in the pre-transplant period, but there are other vaccines which need to be given even after transplant. So there are vaccines like chickenpox. We have always advocated that you should check yourself for chickenpox antibodies pre-transplant, and if you do not have an antibody response, make sure you have got a varicella vaccine. Hepatitis vaccine should be, all vaccination should be completed before transplant. Then pneumonia vaccines, influenza vaccines. It is just that, not enough focus was, or attention was paid to vaccination by maybe, by some of the physicians there. But there is no doubt that most in nephrology, one science where we have been advocates of vaccines. The only vaccine, now vaccines again are of different types. So you have the live vaccines and then you have the inactivated vaccines. Now, once you got a kidney transplant, you are on immunosuppression, there is no question of giving you a live vaccine. So that's the vaccine that you are talking about, but all vaccines are not live vaccines. There are a lot of vaccines which contain inactivated microorganisms or subunits. Hepatitis B notably, we have always completed our hepatitis B vaccination post-transplant, pneumococcal, influenza vaccine, and in girls, we have been vaccinating them for CA cervix. So it is just that
I think Sanjeev's video is not very clear.
Dr. Sanjeev, if your internet is not great, then just mute. You can take off your video and you can talk. Then you'll have better signal.
I think is Sanjeev can't hear you. It's hanging.
Can you?
I think your internet connection is bad. Better.
So what Maryann, I was telling you is that the only vaccines that transplant patients cannot receive are live viral vaccines. At no point any nephrologist has said that you should not be vaccinated. And we have made active efforts to make sure that the hepatitis B vaccination is done. We have made sure that those patients who have not had chickenpox should get the varicella vaccine in the pre-transplant period. And post-transplant, most of us insist that the pneumococcal vaccine should be given, the influenza vaccine should be given, and in young girls, the CA cervix vaccination against CA cervix. So vaccination has been amongst, one of the forties as far as nephrologists are concerned, and but never has there been such a pandemic. So maybe it escaped some of the attention of some of our patients, and let me reassure you that the vaccines that have been introduced till date, none of them is a live virus vaccine. So there is no question that any patient, any transplant patient should not get the vaccine. Yes, there have been more experience with some vaccines, less experience with others. So, but if you have to survive, if you have to, any infection, vaccination is your best bet. And I think we should, as I mentioned earlier, polio and smallpox we could eradicate only because of vaccination. And the only way we will be able to get this get over with this COVID-19 pandemic is that once we get a level of herd immunity in the general population through vaccination.
I think yellow fever vaccine is the only one normally it's not recommended in transplant. Otherwise, as far as I know, you never said don't take any vaccination. As Sanjeev rightly said,
absolutely.
As far as I know, it's only yellow fever vaccine which has been asked not to be taken.
But I just guess we've never been in a situation where every transplant patient had to take a vaccine on such a broad forum. So it's like 100 people now making the same question. So that's obviously creating a lot more noise. And for people, sometimes it could also be a sense of not being aware. I mean, of what is happening. But I'm sure after this answer, thank you, very much, Dr. Sanjeev, for asking us, giving us that answer, and that's going to give a lot more surety to the patient body. And Coming into Dr. Sundar once again. Dr. Sundar, so globally we have different vaccines available and working broadly on 4 mechanisms as of now. But let's break it down to the 2 vaccines that are available, and of course Sputnik, which is coming in. Currently we have Covishield and we have Covaxin available. Both the vaccines working on 2 different mechanisms, Sputnik working on its 3rd mechanism. The question is here, what is the right vaccinations to take? And I'm going to add another question to that once you give me the answer.
I think it's the first important thing is take the vaccination, whatever you get. Suppose there's no choice. In fact, problem is we have got a choice. I would say don't give a choice. And that's what initially the government did. They had only one Covishield and everybody took it. Then we got Covaxin. Now, a lot of patients keep asking me which is the best. So I think still the jury is not out. There was a paper which came out, study of healthcare workers. It came in some of the newspapers. I was also one of the participants. I gave my blood, and there somebody, part of the study said that Covaxin gives more antibodies. I don't think it's true. We still don't know which is the best. But in my opinion, take whatever is available. But there are other concerns. Recently, I had a very important, interesting scenario. This was a young transplant patient of mine who's got a job in Qatar. Now, in Qatar, only 3 vaccines are available. One is AstraZeneca, the other one is Moderna, and one more vaccine. This Covaxin is not available. Now, this fellow wanted to know that company in Qatar told him, don't have any Indian vaccine, come to Qatar, we will give you the vaccine. But this fellow is a smart fellow. He says, I'm traveling in the flight. I would like to take 1 dose of some vaccine, okay, and then go in the flight 2 weeks later so I have some protection. So such a patient, what I told him was, since Covaxin problem is internationally, it is still not recognized. If you want a vaccine passport, still the US FDA is not approved. So people who are traveling abroad, in fact, my niece, nephew who are going abroad for studies, I tell them, take the AstraZeneca, Covishield, because that is recognized internationally. Take the first dose, and second dose, you can probably get it there. So these are things which are not scientific, but the simple answer is take whatever is available, and probably with the help of your nephrologist, if you're there, take his help. But I personally, I don't have any particular choice of any vaccine, any of the vaccines. I don't know about Sputnik because I have no experience. It has just come into our hospital now. I have no idea. But many of my patients, I would say equal amount, at least of the last 50 or 60 patients who have taken, they have taken either Covaxin or Covishield. They have not had any problem. They are doing well. They are doing well. No symptoms. We still don't know the antibody levels. I don't know we have not done the study. We don't know that.
We'll come to that next, Doc. So,
one problem is that, I think one of the reasons for this confusion is that, I am frequently on YouTube. And if you see 10 videos on YouTube, 9 of them are by Google experts. There is some Ankit Agarwal here who comments on everything under the sun. He definitely is not got even an M of an MBBS degree, let alone, A of an MBBS degree. There are several other names, and you hear them with the utmost confidence. 25-year-old young boys lecturing us literally when you hear them telling that this vaccine is better than the other, based on a lot of misinformation on Google, because immunity is not simple. And I would again reiterate what Sundar said, that there's no single head-to-head comparison between 2 vaccines. So it is impossible to say for anyone with any scientific conviction that one vaccine is better than the other. And in that scenario, I think it is remember the Nike, just do it. Just get it, whatever you have.
Okay, thank you, doctors. Dr. Sanjeev, in case you find yourself buffering or anything like that, just you can put off your video, because when you're talking and if you have a situation, then your internet will get better and we can hear you. But as of now, it's been good. Dr. Prasad and Dr. Gulati, do we have any knowledge from your side, any awareness, any studies on the Sputnik? Because the Sputnik vaccine is working a little different, right? The first dose and the second dose is a little is varying from each other. So there's been a lot of questions on that. Do you have any thoughts on that?
Yeah, actually, there is no trial of a Sputnik in India. It has just been launched, and when you look at the mechanism of development of this vaccine, so we have three important kind of the vaccine. One is that mRNA vaccine, that is the Pfizer and Moderna. Other one is the Kovisil vaccine, that is the vector-based vaccines. And third one is your Covaxin, which is live inactivated vaccines. Right? So these are the three different types. Sputnik also come in category of the vector-borne vaccines. So what is the difference between the Covisil and Sputnik? There are two vectors which have been used for, two different vectors have been used for the Sputnik. And one thing always comes in the mind of these pupils, these vectors are adenovirus. Adenovirus-based vectors is there. So they might be reading and getting the confusion that this adenovirus also cause some of the problems in human being. So you might have the confusion that whether you will acquire this adenovirus infection, you would have the respiratory tract infection that adenovirus do. Sometimes the adenovirus cause the GI infections and GI problems. So, but one thing they should be very clear that this is the vector. They are inactive. This virus does not replicate. These are a non-replicating virus. When they enter into the body, this is just only used to carry over some of the proteins from your COVID, your SARS-CoV spike proteins, and that is entered into your body, and then that stimulates your immune system to form the antibody, and then that also stimulates your T cells, which is T lymphocytes in your body. Whenever in the future you would have any infection, your already formed antibody will neutralize it, or your already formed or activated T lymphocytes will try to kill that virus. So that is the whole the mechanisms. So when you look at the mechanism, there is no much of the difference. This all depends on the trials and inactivated vaccines that Dr. Sundar was telling that vaccine and this inactivated vaccines formation is a standard process. We all know polio virus, there are two kinds of the polio virus vaccine. One is the oral polio, which is attenuated vaccines. One is the inactivated vaccines, injectable vaccines. But these vaccines are very much effective because whole of the virions are inactivated and then that is entered into your body. So just that is inactivated. So that does not multiply in your body. That just gives you some antigenic stimulus to increase formation of your antibody and activates your T lymphocytes. Whenever you have the future infection, then this is going to neutralize and kill the virus. I think when you look at the mechanism, all three vaccines are equally effective. All three kinds. Only the trials show that only the newer kind of the mechanism which has been adopted this time in the formation of the vaccine was mRNA vaccine. That was the Moderna and Pfizer's vaccine. This was the first time introduced mechanism for the formation of the vaccines. So you should have the more suspicion on that. Vector-based vaccines and inactivated vaccine is the old way of formation of the vaccines. So we should be much more confident over that. But that mechanism is a modern one. And the efficacy has been shown in the tune of the 94-95%. And then definitely the mechanism is there that mRNA goes into your body. When they stimulate your antigen or antibody formation is there, that kills off, remove your mRNA from the body. That does not remain in your body. So, and then after that antigenic stimulus, there will be formation of the antibody and then activation of a T lymphocyte or B lymphocyte. Getting after the infection, again, you would be free from that infection. This is the whole mechanism. The problem only in the renal transplant recipient, because these transplant patient on immunosuppression, chances of developing seroconversion is far less. And even the best of the vaccines, that is the Moderna or Pfizer mRNA vaccine, which has shown efficacy of 94%, 95%, you all are aware. Efficacy in renal transplant recipient was less than 50% in USA. And that study is odd. So what I will suggest, so whenever you are getting vaccines, get the vaccines for sure. This is looking like totally a safe vaccine. Either the Kovisil or Sputnik or Covaxin, anyone you can get, you should get one. But always be aware that getting the vaccine is not everything. You should continue with the COVID appropriate behavior. That is very important because you know that many of the mutant viruses are coming up and this may cause problem again. And all the vaccine or antibody which has been produced with your vaccination may not be able to neutralize all antibody. So that should remain continued. But we all as a transplant physician community, we advocate strongly that everyone should get whatever the vaccine they are able to get.
Thank you, Dr. Prasad. Dr. Prasad, my next question also will go to you. That was Dr. Sundar's question. And the question to you is, a few of our patients, we've been testing their antibodies, there's protein spike antibodies, and the quantitative antibodies test. The thing over here is, even firstly in my case, my husband has also taken both the doses, and the patient has only picked up a minimum, not even a minimum dose, and still shows negative, 0.40. And one of the things that all our nephrologists say is, you will need a booster dose, which we will discuss a little later from now. But there's something else that caught our attention. They did mention to us that other immunity cells could have been boosted. So I'm trying to understand, to be safe and protected from COVID, what are these other immunity cells that we are talking about?
Yeah, I have just pointed out you that giving any antigenic stimulus, your body system has one immune system. That is, one is called the native immune system, and that is called adaptive immune system. Native immune system kills immediately anything which enters into your body. That is your WBC kind of things. Adaptive immunity is something which, whenever any antigenic stimulus, like the virus, virus particle is going into your body, that stimulates your immune system. And that immune system acts in the two way. Your T lymphocyte is there. Lymphocyte is there in our all circulation, that we all understand. These lymphocytes, there are two kinds of lymphocytes, T lymphocyte and B lymphocytes. T lymphocyte, there is one cytotoxic T lymphocyte that immediately catch these viruses and will kill if your immune system is a good one. Some call the T helper cells, TH4 cells, T lymphocyte one variant that again gets stimulated, and that secretes some of the cytokines called interleukin 2, and that again gives a stimulus to your B lymphocytes. Probably something has come into your body and that is dangerous for you, so do something. And that B lymphocytes, what do they do? Start forming, converting into plasma cells, and plasma cells start forming then your antibody, and this antibody has the neutralizing effect on the virus particle. Whenever they comes, this antibody will come and neutralize your viruses. So this is the one mechanism. Other mechanism is there. Once this antigenic stimulus is going, there is a called memory cells. This memory cells remains there, and that remains in the memory. So even if your antibody level comes down, it is not there. Whenever you have the second infection, this memory cell get activated. Probably there was something similar like things have come and before that has harmed us. So they will activate your immune system. This memory B cell activate your immune system, and then your immune system get activated. Again, the similar effect of the killing of the virus from the lymphocytes, increased formation of the antibody in that response, and neutralizing effect on the viruses. So that kind of things is there. And there is already one study came recently in Nature. Nature is one of the most reputed journals of the science. And there they have shown, they have done the bone marrow examination after giving the vaccination and after infection. And what they have seen that probably memory cells remains there for longer period of the time. They have followed this patient for a year kind of thing. So memory cells remains there. So this kind of, even if you are not getting the 100% protection level of the antibody, but if there is anything in your memory B cells and you are not totally depleted with the memory B cells, then there is chance that there would be some degree of protection at least with this virus. So that is very important to understand that the God has given us a lot of immense power of the immune system, native immune system, and then you have something like the adaptive immune system. So keep that. Only thing that in transplant patient, what happens now, our immune system is totally depleted whenever you are getting this steroid and calcineurin inhibitors. Calcineurin inhibitors suppress your T cells functions, and so that makes the chance that the seroconversion would be relatively less. That as I have pointed out, but definitely we should always have this vaccine, even if the seroconversion is less. This outweighs the benefit of doing the harm, because there might be many questions of about the adverse effect of this vaccine. We'll take on later on, but definitely the benefit is far more than the harm.
Okay. Thank you, Dr. Prasad. Dr. Sanjeev, my question to you would be, would you recommend transplant patients doing their renal test pre and post vaccine? And do you think that nephrologists should make this compulsory? I think that Dr. Sundar, we also had a short discussion on this in the past. And
my answer is no, because none of these vaccines have been, now we have experience. They may not be effective, but there's no harm there. So they're not going to trigger a rejection. Okay. As I said, yes, there is a question that studies from US have shown that about 30% of them are going to get an antibody response. And there is already a suggestion now coming in that these patients would require booster doses of vaccines. But in a panic mode, getting a test done pre and post vaccine is just not on. So you have to remember that the test that you are getting is being done by a machine, and no machine is perfect. It will create unnecessarily panic. There is a phenomena called inter-assay variation, which means that if you divide your blood into two parts and you run the test twice, there is some degree of variation that is going to be there in the sample. And this will unnecessarily create a scare or a panic. So the guidelines are very clear. Just go and get your vaccine done. That's it. That's end of story. There's no point. And regular monitoring, yes, you have to get as a part of your period. If you are in the first year post-transplant, you're getting an annual test done, yeah, go ahead and do it. But just specifically for the vaccine, the answer is no.
Dr. Sanjeev, over here, we are talking about the renal function test and the CBC test, right?
Absolutely. So the guidelines are very clear by the international community, by our own this thing, that you don't need. The only thing is that the general principle of vaccination is that when you are going ahead with the vaccination, you should be infection free. Okay, so that you are able to mount an. The second thing is that you should not have had a vaccine recently, like a pneumonia vaccine or an influenza vaccine. So there is a minimum gap, ideally of 4 weeks, can be shortened to 2 weeks. That's about it. Other than that, everybody should go and get a vaccine.
Okay, doctor. Thank you so much, Dr. Sanjeev. Dr. Sanjeev, we've had a few case studies, and one of it was after the vaccine, whether it's a coincidence or whether it was a trigger, I'm not very sure. And again, this was particularly my own husband itself. After his first dose of vaccine, exactly 3 weeks post 2.5, 3 weeks post that, he picked up herpes zoster. And he's never had the virus activated before in the last 11 years that he's been on the journey of CKD. And this is a second transplant. So our nephrologist thought that it probably could be post the vaccine. Do you have any suggestions? While it was not confirmed to us, I want to mention it on this forum, but do you have any views on that? Could that be a vaccine related because your immunity dropped?
All right. So, as I said, we have ample experience with other vaccines in our transplant patients. Herpes is certainly one of the commonest infections that gets reactivated. But I can tell, at least in my experience, I have never seen a patient developing herpes following vaccination. So my personal take on this is that it's probably a coincidence, but I think we can have the experience of other learned panelists.
I think I also agree with Sanjeev. I don't think vaccine causes herpes. A lot of our transplant patients do get herpes. In fact, even without transplant, my son a month ago, 2 months ago, because of stress at office and all, he got very bad herpes. He had to be admitted. He had a facial palsy. We had to use steroids. So the herpes can come due to any stress, reducing the immunity. I don't know, unless somebody is so worried about vaccination and then the immunity is low. I don't think vaccine per se causes herpes zoster. I'm quite clear in my thought process.
Vaccine stimulates immunity, whereas you get herpes when your immunity is
Please
suppressed.
go.
So I think the two are just not going together. Yeah.
Thank you, doctor, for that. Dr. Sundar, I'm going to ask you a question somebody's asked on the John Hopkins research. And this was the research, for those of you who is not aware of the research, this was the research that showed the number of people that actually picked up immunity picked up antibodies post the first vaccine and then post the second vaccine, which was a smaller number, and the others did not pick up the antibodies, for which Dr. Prasad has already given us an answer what is actually happening behind that. But Dr. Sundar, do we have any idea on what were the variables considered in the John Hopkins study in terms of the age, the time of transplant, the race, what vaccine was used? Do we have any studies on that?
I think I personally don't know much about the study. I think I would ask Sanjeev or Narayan to answer the question, because I'm not able to recollect that study. I don't know whether I've gone through it. I request Narayan or Sanjeev to go on that, if you don't mind.
Yeah, sure.
I'm aware of the study, but can you repeat your question, Maryann?
So in the John Hopkins study, the study showed that a few people had picked up antibodies, and there were reports of few picking up antibodies, and there was a group that did not pick up antibodies. Do we have an understanding on what variables was this vaccination given?
So there was only about a third of these patients after 2 doses of vaccines were able to develop an antibody response. And this is not surprising because, at the onset, all of us have said that transplant patients are on immunosuppression. So an immunosuppressive agent inherently suppresses your immunity, your ability to mount an antibody response. So that's why there is a current thought among the transplant community, about the doctors, that perhaps these patients would require a third dose. There's another group of doctors who suggest that, maybe even to a third dose, they may not mount third dose of the same vaccine, they may not mount a response. So it would be wiser to mix vaccines, but these are studies in progress. And I think it's a very exciting area. And as has been said earlier, we are learning new things every day. But it's perfectly normal, in our transplant patients to expect a reduced response to vaccine.
I like when you said it's a really exciting area. And yes, doctor.
Yes, in addition, you can think there are certain population who are always have the less seroconversions, like elderly population. Elderly populations with the increasing advancing age, they have the reduced immunity, and they are less likely to convert. Seroconversion would be relatively lesser than their younger populations. Like any person other than renal transplant also getting any degree of the immunosuppression would have less chances of developing the seroconversion. So there are certain factors, inherent factors, which are bound to have the less. Definitely our renal transplant patient, like the dialysis population, and the dialysis population already a study came out. A dialysis patient on the dialysis has less chance of seroconversion than the normal population. But definitely, despite being all that odds, this whatever the seroconversion is there, when there is no treatment for any of such effective treatment for this viruses, I think it is always better to go ahead with this vaccination. So that is the most important message that should go to this public. So there are certain factors. Any study will come out that the elderly populations, diabetic populations, your patient on any kind of immunosuppression, renal transplant recipients, dialysis population, CKD populations, these patients are likely to have the less seroconversions than normal population.
But I think I think this point, a lot of patients, the transplant recipients ask us whether they should stop their immunosuppression. I think there is a lot of confusion in this. If you talk to the rheumatologist, they stop the medicines, immunosuppression. They can afford to stop, because what happens in an arthritis, the pain will increase. With a transplant, that is not so. If you stop the immunosuppression even one day, you will lose the transplant kidney. That is so we tell our patients, do not modify the immunosuppression. They are getting confused when we say vaccination should not be given in immunosuppression. No, vaccine is advocated in immunosuppressed patient. Transplant is also immunosuppressed, but normally we will not stop the immunosuppression or modify the dose for the sake of vaccination. But this is not so with rheumatologists. Rheumatologists, immunologists invariably tell them 3 days before vaccination, 3 days after you stop, to mount antibody. They can afford to do it. They've got luxury. Because at the most, arthritis can become worse, psoriasis can become worse. But that's not the story in transplant. So my message again, in transplant, we normally do not do anything with immunosuppression. You have to continue the immunosuppression. I'm sure Sanjeev and Narayan can elaborate on that.
Yeah, definitely, sir. I agree with you. And I don't think any person should do this mistake during their lifetime without advice of your nephrologist, without advice of your renal transplant physician. Don't stop any degree, any immunosuppressant. So that is the one thing that is, you can say that is a lifeline for you. That goes your life go through that. So that is very important, sir. That message should always go to everyone. That mistake should not be.
Thank you very much, Dr. Sundar, for bringing up that point, because that was actually my next question. And the question, I'm going to say the question while we've already discussed the answer. The question was, should I stop my immunosuppressant drugs when I take any COVID vaccine for the vaccine to work? And the answer has been clearly a big no.
You should not stop
the drugs. You cannot make any changes while you're taking the COVID vaccine. And thank you, Dr. Sundar, for actually.
That is what, see, the transplant patients are also on other drugs. Some of them are on heparin, anticoagulant. Those things we may have to change based on what the physician says. But I'm talking of the immunosuppressive drugs, commonly tacrolimus or cyclosporin, azathioprine or mycophenolate, and steroid. These three we never stop for the sake of vaccination.
One thing I want to make clear them that there might be some confusion in that our group of the patients, because many times we modify immunosuppression during the active infection. When they are hospitalized and they have severe COVID, then during that period of the time, we stop some of the medicines or reduce the dose of this. But they should understand the difference between these two periods. When you are severely affected with this COVID-19, severe COVID-19, this is a life-threatening condition where if you are not bouncing back your immunity, you are likely to die off. So there you have to balance between the life and the drugs. And this is the reason why we do, and that is done under the controlled environment, where your doctors are looking after you every day, whether your urine output is fine, your serum creatinine is fine, your everything is there. So that is a controlled environment. So that message should go. They should not think that the doctor has done this and now today he is telling he cannot do this. So that message should not go down, because during the period of this active infection, his immunity level is very, very low, already very low. So chances of during that very active infection, chances of rejection becomes a little less. But as soon as you will come out from this condition, your immunity will go up and you have immediate rejection if you are not on immunosuppression. So don't take this as all together. Both are the different time frame. One is totally controlled environment, one is totally uncontrolled environment. Don't do this kind of the mistake of stopping immunosuppression when you are out of this.
Dr. Prasad, I'm going to extend that question a little more, and forgive me, it's a very curious question, and it could also be a very silly question that only probably God can answer. But I'm just going to put that question on this forum. Do we have an understanding within the immunosuppressant in the John Hopkins research why there was a group of transplant patients who were all immunosuppressed? They could develop antibodies and the others couldn't?
Yeah, definitely. I have told you there are several factors which affects this development of immunity. What is happening when you are giving the antigenic stimulus to your body, I have already told you, this is the something which is there whenever any virus or any particles comes, foreign body comes into your body, there are some antigen presenting cells that comes into the picture, they present there. So all depends on the what is the immune status of your body. If your immune status is that much, where you are likely to develop the your immune system is likely to be activated. Like there is some activation of your T cells, some activation of your B cells, then they are converting into the plasma cells and formation of the antibody. So that kind of the persons. And one person is there who is for the long time immunosuppression, and your immune system is even not bother whatever is coming into your body. So suppose simple, what happens? One of the important, just I am giving you the example for understanding of this our patients. Like suppose one normal person is developing mucor. Mucor, even experimentally, it has been shown that when you can introduce mucorales intravenously, that will be cleared from your body. If your immune system is good, mucormycosis, which came recently into the picture, they do not develop infection. Your immune system is good, they will clear out. But when your immune system is weak, they are not likely to activate your system. So this happens not only in the transplant patient. Transplant patient, two kind of patients are there. There are at least, otherwise it will be very difficult to live on. Because if your immune system is totally knocked out, every day you would have some infection and patients will die off. So immune system, what we do in day-to-day practice, what nephrologists do, they balance the degree of immunosuppression with your incidence of infection or immunity level. Immunity should be such that you should not have the day-to-day common infection, and at the same time, the immunosuppression should be that much that can prevent rejection. So that is the balancing act, and there is no immunometer. What we say in day-to-day practice, there is no immunometer where to fix this. Scientists are working on, but these are difficult. We can get the CD4 cell count, we can get the CD8 cell, but every day you cannot do this. This is cannot be practiced every day. So what is this? This is the general sense of our colleague, our nephrologist, Dr. Sundar, Dr. Gulati, who sense that probably this patient is getting over immunosuppressed, you should reduce a little bit more of the steroid, not 10 milligram, make it 7.5 milligram, make it 5 milligrams. Probably this patient is developing CNI toxicity. Why not keep the CNI level at high always? There will be no rejection at any point of the time. But you have to balance between the point of the rejection and where the patient is likely to get infection. So this is the reason why always there will be in the community, some person will have the seroconversion, some will not have. Even the Moderna vaccines, even the Pfizer vaccine, 5% or 6% people are not responding. Even with this Kovisil, 30% of the normal population is not responding. 70% only is showing some seroconversion. So there are multiple factors. How your immune system is likely to respond. How this, what was the status of your immune system when this vaccine has been given? Why it should not be given in the periods. One more important thing is that whenever the patient getting transplantation, whether the early period of transplantation when the patient is at maximum degree of immunosuppression, we should avoid taking this vaccine, because during that period there is no chance at all of getting the seroconversion, because your immune system is very much weak. You are at the heightened immunosuppression. So there are several things which affects the seroconversion. It is not only the group of the transplant community. All transplant patients are different.
Yeah. Okay. Thank you, doctor. When you mentioned the heightened immunosuppressant patients, that brings me to my next question, Dr. Sanjeev Gulati. A new transplanted patient where your immunosuppression is really high and your whole system is really weakened, when do you suggest that they get their vaccine post their transplant? Yes.
Yeah, so for the first 3 months, these patients are on a very high degree of immunosuppression, and the current guidelines suggest that you should postpone vaccination to beyond 3 months. If possible, get one shot about 2 weeks pre-transplant. That also there is no point in giving a day before, because that is going to go down the drain. So if you can If there is a period of 2 weeks, certainly give it pre-transplant. But once the transplant is done, I think we'll wait for 3 months, because at the end of 3 months, we reduce the immunosuppression to among its lowest level. That's the time you should go ahead.
Okay. Thank you so much, Dr. Sanjeev, for that answer. Dr. Sanjeev, can I go on with the next question also with you?
Yeah.
Since you already spoke about the recent research. We also heard of the recent research of the booster dose that is coming up. There's been studies where a lot of immunosuppressant patients have showed heightened reports of picking up reporting antibodies after the third booster dose. And I think some work has also started off in India with the nephrologists in terms of, do we require the booster dose for immunosuppressant patients? Do we have any idea what is happening exactly in our country for the same?
So I think as of now, the government, there are very clear guidelines, and to the best of my knowledge, nobody is allowed to get a third dose, because all vaccinations are under the COVID app, CoWIN app. It is impossible for you to get a third dose.
Unofficially you can get.
Yeah, unofficially. So there, I think, unless there is a trial going on, I'm not aware, because the idea, the thought process behind this is that we should try and maximize the number of people in the community who can be immunized. The doses have to be, used optimally. But certainly, if somebody asks, should you get antibody levels for the general community, we are saying no. But yes, the current research that is coming in for the transplant patients, yes, perhaps you should get your antibody levels done, because it may indicate the need or select a subgroup of patients who would require a third oblique booster dose.
Actually, there is a New York surgeon, nephrologist surgeon who had a heart transplant, and then he took the third dose, and after the third dose, the antibody level went up, and I think that's one of the studies.
Yeah, one of the studies which has been published, that is from the John Hopkins only, and that is published in the Annals of Internal Medicine, and that has shown that the three doses of giving the vaccine has the better seroconversion than getting the.
It is similar to our hepatitis B vaccine, where we give in CKD. The CKD, the hepatitis B, what we give is double the dose and more frequent compared to the normal hepatitis B vaccination, which we give in the normal people. Whereas CKD patients, we give double the dose at a frequent 0, 1, 2, 6 months. Whereas in the normal population, the booster is different. That is similar pattern.
So, sir, I think that would be the standard of the care in the transplant community again. I think there are multiple trials going on the third dosage. Now, particularly for this vulnerable population like transplant recipients. There is a small study out there showing that third doses might have the better seroconversion than the two doses. And I think as we have experienced in the past of using the double doses and more number of doses of the hepatitis B vaccine for better seroconversion, that might be the standard. Another important thing is might come at the adjuvant therapy. Like during the early period of when there was no so much of the effective hepatitis B vaccine, some of the adjuvant, GM-CSF and some erythropoietins, they work as an adjuvant, and that might have the better antigenicity and better seroconversion. I think that kind of the things will likely to come in the future. It is quite possible. It is quite possible. Some people are thinking of, there are one thought going on, get the two doses of one doses of one vaccine and get the third doses of the other vaccines. So that would have the different kind of the antigenic stimulus for the body to form this antibody. So that kind of the trials are being designed. I'm just telling you, and this would be, answer will only come after these trials will be completed. So there are thought process, two doses of one kind of the vaccine, third doses of the different kind of the vaccine, one doses of the one kind of the vaccine, one doses of another kind of the vaccine with a different mechanism of actions and with a different level of the immunity. But this would be the trial process. So we should not practice. At present, the practice for informations to all of them, get the similar kind of the vaccine. If you are getting the first dose of the Kovisil, get the second dose of the Kovisil. First dose of the Covaxin, get the second dose of the Covaxins only. So that is present recommendation. But it is likely that evidences may emerge in the future.
Okay. Dr. Prasad, it's time for your question also, and we'll probably soon have to wrap this up. A patient says, even Dr. Radhika has written over here, but let me put on the primary question that I received. A CKD patient is also a cardiovascular patient and has had the problem of blood clots and has taken the Covishield vaccine. And there was a study of clotting when the Covishield was taken in the research of the Covishield in such a patient who's had a cardiovascular issue and blood clotting in the past. Would you recommend that they take a blood thinner?
I think this is a very, very, very important and pertinent question. I think, what I can say you that everyone understands that there is COVID during the COVID period or SARS-CoV-2 infection, there is increased thrombogenicity and there is increased chances of the coagulation parameters go up. So there is always this fear will come in the mind of these people. And I can say you there when in between the trial, when the AstraZeneca, there was some persons who developed this kind of the complications. Trial has been stopped, and then the trialist has investigated, and they do not find the direct correlations or direct association of this vaccine with this development of thrombosis kind of things. So that was no direct association. So, and after that, they have again resumed this trial. And the trial has been completed and published. So that things should be clear in their mind. Other important thing comes whether really, if there is any potential. Definitely we understand our patients getting this CNI, getting the steroids and multiple diabetic, there are high chance of heterogeneity is there. And so blood thinner, many of the patients are getting this blood thinner like aspirin and but getting the vaccine outweighs their benefit than the harm. It is likely that very rare side effect is there that there would have the very activation of your coagulation system with this vaccination. There is very less chance. Harm is looking like relatively far, far less than the benefit which you are getting with this vaccination. So we think, and we all as a community of transplant physician or nephrologist will say, kindly go ahead with this, take the precautions. Don't be dehydrated during that period of the time. Take precautions of everything. Drink a lot of water, drink this, whatever you have the hygienic food during this period. So you should not be dehydrated during that period of the time. So during the dehydration, what happens? Your coagulation, it is possible that you might have the more thrombogenicity during that period of the time. More coagulations, activations might be there. So try to avoid that kind of this, surroundings. But definitely we will advocate you should go ahead with the vaccine. Don't stop this taking the vaccine for this. Benefit is far, far more than the harm.
Yeah, so Dr. Prasad, what I understand is a person who's on CKD and also has a cardiovascular issue, and if he's concerned about the blood clotting post the vaccine, eliminating the fact that Covishield can cause blood clots, take precautions and take the blood thinners is what you would recommend.
Yes,
right?
yes, definitely they should take.
Thank you, Doctor. Dr. Sundar, my question will be next to you. And the question is, somebody who's recovered from COVID, the normal time given for the vaccine right now is standard 3 months, right? So there was a discussion within the fraternity saying that what in that period of 3 months if we are hit with another strain, a new strain, and we can be infected by COVID. Would you recommend that a month to 6 weeks or maximum 2 months later, we check our antibody levels earlier than 3 months? And if we do not have antibodies in that 6 weeks, do you recommend taking the vaccine earlier?
See, normally, we seldom see repeat infection like that, with different strain. I have not seen like that. It is not within 2-3 months. I mean, I have had one transplant patient who had within a year. Last year, she had COVID again. After a year, she got. So I would suggest that person who's got COVID, wait for 2 to 3 months, ask for the protocol, and then take the vaccine. In fact, having the COVID infection plus the vaccine their moral, I would say they are the best. Their antibody level will be so good. They will be ideal situation. In fact, that is the ideal situation. Even in my own case, I wish I had mild COVID and then I take vaccine because I'm sure I will not get COVID again. Or even if I get COVID, I will not die. That is the reality.
Okay. Dr. Sanjeev, you have your thoughts on this, Doc?
Sorry, can you repeat again?
I repeat the question, yeah. The question came from a transplanted patient who's had COVID.
Yeah.
And
Okay.
the
Time period, right?
time is 3 months. It's 3
Yeah.
months for taking the vaccine. But the patient is concerned that what if he's hit with a new strain and he's just 6 weeks post recovering from COVID. So he wants to know, do I check my antibodies? And if I don't have enough antibodies, do you think I should take the vaccine earlier than 3 months?
Yeah, 1 to 3 months is what the recommended period is. Anywhere between 1 to 3 months post recovery, there is no need of checking the antibodies. I would wait and because currently it is believed that the antibodies you get following an infection are not going to last forever. So even those people who have recovered from COVID should be getting a COVID vaccine within a window period of 1 to 3 months post recovery.
Okay. Our next question pretty much is answered in this answer that Dr. Sanjeev has just given us. And I'm going to read out the question so that the person who's written the question will connect to the answer. If the patient has recovered from COVID 2 weeks, after 2 weeks, and they developed antibodies in their bodies, then how much time this antibodies will last, and after how much time they were supposed to go for the vaccination? I think the doctors clearly said a month to 3 months, is when you can go on to take your vaccinations. You don't have to check your antibodies to know if you have antibodies. Let's take some questions that have come over here and we can wrap up the session. The question is to our esteemed panelists. I am a transplant patient in 2018. I have 2 questions. What is the effect of vaccinations on transplant recipients who are prone to thrombosis? Does the vaccine cause clotting? I think we can refer back to Dr. Prasad, Narayan Prasad's answer. I think he's given us a fantastic answer. Take precautions if you're concerned, no problem, but there is no study to say that.
I think taking the vaccine is very important because getting a clotting tendency after the COVID infection is more dangerous. Vaccine causing clot, it is only theoretical in my opinion. I think there is no question of that. Fear should not be there. The vaccine is going to get clot, and that's why I must not have vaccine. And that's not, we won't accept that argument. I think everybody should take the vaccine.
And the second question, the same person has asked, there are vaccines against COVID-19 under multiple names. Which vaccines shall be the best for the patient prone to clotting? I think the answers is already given. And I think we can go with the last and final question. And I'm going to open up the question to any of the doctors who'd like to take this question. Shantanu has asked, probably the answer is already given, but I'm going to repeat the question. A spike protein test results of less than 50, in brackets, in fact, less than 21 after the first dose of the vaccination, Covishield. Does it mean antibodies are not present after the vaccination for the post-transplant recipient? I think, doctor, you've already given the answer for this particular question, right? But would you like?
I think what he's trying to ask us the questions that seroconversion is usually, I think that is John Hopkins study which you are talking about. This they have also shown the first dose seroconversion was only approximately 20%. When they have received the second dose, it gone up to 54% kind of things.
Yes.
And the majority of the studies have shown in renal transplant recipients seroconversion is relatively less. But I have shown you there are other different mechanism of the protection levels that is going on in your body. So I think there is no harm in getting this. Don't go by this that you have not to take. Don't excuse. Try to find out the excuses that you have not to get this vaccine. You have to get the vaccine. That is most important. More important than this. As we have the emerging the Delta and Delta Plus kind of the variants that we all understand, and neutralization effect of this vaccine on these Delta Plus and Delta variants has been found to be less. So more important, even after getting the vaccination, every protection level, what is the COVID appropriate behavior should not be left out. That should always continue. That is the most important barrier in developing, not only from this, forget about this SARS-CoV-2 infection, forget about this COVID-19. It protects you from many multiple respiratory tract infections. Influenza getting in renal transplant recipients, many times it is life-threatening. So many airborne diseases are prevented through this. Many of the allergic rhinitis has gone down. It has been seen that many of the, after this implementation, many of the disease percentage came down.
I think
When the
TB,
road
TB
traffic-
has come down. TB also
Even
has
road
come down.
traffic accident came down because of the lockdown. Because people are not going out. So there are some prospect there, and I think we should not COVID appropriate behavior is the most important thing for everyone. That they should understand, despite having this your vaccination.
Thank you, doctor. One of our friends have asked us, can we take the flu shot after the COVID vaccine? I think Dr. Sanjeev Gulati is the answer.
2 weeks.
And if not, you can even come down to 2 weeks after discussion with your nephrologist. Right. So that we have the answer there. Doctor, before we close the session, for those of them who want to check their antibodies, because we've been asking a few patients to check their antibodies and let us know whether we have to understand the clinical study of understanding if we picked up antibodies so that we can work towards the third, if we need to take this up and work towards a third booster dose. In that case, what is the test that should be exactly taken for patients to check their antibodies? Because when I checked for my husband, I did so many tests.
Yeah, I'm just giving you the answer of this. I have recently designed a trial for this effect of the COVID vaccinations with this Kovisil and Covaxin, and I have submitted ICMR project. And there we are going to test whether what would be the effect of this vaccination of your T lymphocyte, B lymphocyte on the memory lymphocytes. So, and then what is the seroconversion with these two vaccines after 2 weeks of the first dose and 4 weeks of the first, 2 weeks of the second dose. So that is under the plan. Definitely the most easy, it is ideal to get the test for the memory B lymphocytes. But it is not that easy. Memory lymphocyte testing is not in day-to-day practice is possible.
Most of the lab will do spike antibodies. So most of the labs
utilizing antibodies against spike.
So only thing which is possible easily is the antibody testing. So that can be done easily, and that is available in the pre-market also. So you can get this test done, and you can see the titer. But even it is not exactly defined as what titer is protective. So somebody having the titer of the 100, 200 is developing infection.
Somebody with 20 are not getting.
And someone is not getting with the 20 is not getting the infection. So it is thought that probably the titer of the 250 more and 300. This also depends on, as Dr. Gulati has pointed out, this also depends on the assay. The newer assay which has been which came into the market that is showing the linearity up to the 40,000. So someone is getting this titer of the 20,000 and 30,000. But this titer, whether going to last for how long? My titer is 28,800. My anti-COVID antibody titer is that much. But I don't think this is going to last for a year kind of things. This will likely to deplete. This will deplete. So there are several things which are under the way or under the trials. It is possible that by the end of this year or the next years, answer of the many questions will come up. But for that period of the time, we will advocate all together that you should go for the vaccination and continue with your COVID appropriate behavior.
Yes, doctor. And thank you very much, Dr. Prasad, for that answer, and Dr. Sundar and Dr. Sanjeev as well. Well, we've come to the end of our session, and for a change, I want to request the doctors to sign off and with a few words of what is, according to you, the way moving forward with the Delta Plus variant coming in, and do we have any plans in mind? And we'll close with that.
I think there's no two things about it: vaccination. There's no other alternative apart from vaccination. And then following COVID appropriate behavior is important. and there's no shortcut to that. I know it's a difficult period, but I'm sure with 80% of the population getting vaccinated, things will change. Even the Delta variant or whatever, we still don't know whether the vaccination works. But by and large, most of us feel the vaccine will work. So it's important. So the take-home message is, in transplant recipient, the vaccination is not going to harm you. It will help you. It will help your family members not getting the disease. And even if you get the disease, it will be in a milder form. It won't kill you. So take the vaccination. That is my message.
Yes, Dr. Sanjeev Gulati.
Yeah, vaccination and SMS. SMS is S for social distancing, M for mask, and S again for sanitization. Don't forget that. So vaccine and SMS. Just remember this, you'll be safe.
Good.
Thank you, Doctor. And Dr. Narayan Prasad.
Already told us the most important thing that I agree with the Dr. Sundar and Dr. Gulati, that the most important thing is the vaccination that is available to all of you, and with the many of them, this is freely available, or you can get it free. So that is the one thing. And other important thing is again the COVID appropriate behavior, distancing, unnecessary walking. Otherwise, also we say our renal transplant recipient, don't go and mix up with the people who are having the cough, who are having some degree of infection. So, and then at present, you will see these kind of the smaller infection becomes less among the, particularly we see in renal transplant recipient. So COVID appropriate behavior, the distancing, having the masking, and sanitizing yourself off and on. So that remains the crunch of from the prevention of this COVID-19.
Thank you once again on behalf of the entire fraternity. Thank you, Intas, for putting this together. Of course, special thanks to all our 3 doctors who joined us here this evening.
Thank
and
you.
so honest, giving us so much of clarity of what we wanted to know. I don't know if the others who've been a part of the session could take home, but I'm going home full-hearted, being very convinced that yes, I'm on the right track, and vaccination is the only hope that we know of right now moving forward to keep us safe. So please get yourself vaccinated. I think with all these answers, we're now confident to move ahead with an vaccination. So thank you very much, doctors, for joining us. And all our friends who have come in from the Kidney Warrior Foundation and other foundations who have joined us, our friends from INTAS. Thank you. And this is us signing off, wishing you all a very good week.
Can I clear one thing more?
Yes,
one
doctor.
thing more that what I want to convey, that they have all the chance that many the rumors are coming that after 20 years, 30 years, they would have the Alzheimer's, and because mRNA vaccine is causing some problems there. So that thing should also not go into your mind, because this mRNA which is given and entered into your body, once there is a formation, the same antibody clears this viruses out of the body.
Okay.
So it is less chance with this present mechanism and understanding of this present mechanism. There is less chance that any adverse event is likely to come even in the future. So that message should also go. Don't be scared of that you would have Alzheimer's after 40 years or 50 years of the time.
And don't listen to WhatsApp University or YouTube
Google
University. Believe in the experts. Look at the credentials of the experts, because the social media is, to a large extent responsible for the havoc or the confusion in the minds of people. So know whom to contact and, listen. Look at the credentials, not just any Tom, Dick or Harry. All right.
Thank you everyone. Thank you,
Doctor. Thank you,
ma'am. Thank you, Maryann. Thank you, Radhika. Thank you, everyone.
Bye, doctors.
Thank you. Bye.